So for everyone who's joined on Teams, my name's Hameed. I'm the training program director here at the Academy, and I'm going to show you guys some interesting cases to hopefully whet your appetite for a career in radiology. So the cases I'm showing mostly are CT. So just as a very brief introduction, so that we're all sort of on the same kind of page, I'll just go through a little bit of sort of CT basic, very, very basic physics and anatomy, so that we're all looking at the same kind of things and we know what we're looking at. Um, so this is a CT scan, as you can see. This is an axial view, so it's a slice through the abdomen, okay, like that. Um, when you're looking at a CT scan, what you've got to remember is basically CT is effectively just like a plain film, but it's like you've taken X-rays from 360 degrees around the patient. Uh, and that's basically what a CT scan is. You take X-rays from around the patient, and then you plug those X-rays or the data from the X-rays into a computer, and then the computer will put back an image. Okay, and because you've taken images from around the patient, it effectively acts like a bit like a simultaneous equation. And so the computer then puts it all together, and then it can create a 3D image of what's inside the patient. Um, so that's the first thing to understand about CT. The next thing is about what we're actually looking at here. So some things are bright and some things are dark. And just like on plain film, if something is of high density, it's bright. If something is of low density, it's dark, essentially. Okay, so it's exactly the same as you'd think of as plain film. So air is very dark. So for example, you can actually draw a little circle around around the tissue, and it'll actually tell you what we call the Hounsfield unit value, which is basically just a measure of density. And it'll tell you what that is. So here you can see this is the air outside the patient. That's around about minus 1,000 Hounsfield units. That's what air normally is. Then you've got subcutaneous fat, which is around about minus 100 Hounsfield units. Okay, so you've got air at minus 1,000, fat at minus 100. And then you've got sort of various fluids. So here we go. Let's measure that. There we go. So that's fluid in the gallbladder. Pure water is about 0 Hounsfield units. Okay, that's how the machines are calibrated. But fluids in the body obviously contain electrolytes and proteins and things like that, so they tend to be a little bit more dense than that. So we say generally between 0 and 20 Hounsfield units is fluid. Okay, so that's that. And then you've got sort of tissue. So for example, muscle, you've got liver, you've got kidney, you've got various other tissues, and they will vary from about 20 over 200 or 150, depending on whether you've given contrast or not. And then you've got bones, which will be over 100. Okay, so that depends. There you go. You can see that's about 400 there. Cancellous bones a little bit less. And then you've got metal, which is over 1,000. Okay, understanding those kinds of Hounsfield unit ranges is one of the core things that you learn in the first year of radiology, because it can actually help you figure out what something is made of. Okay, so for example, here we have a kidney, and we've got a thing coming out of the kidney. And if you're wondering, what is it? Is it a cyst? Is it a tumor? What is it? Right? You can measure the Hounsfield unit value. So here you can see Hounsfield unit value is quite close to 0. So what do you think that is? It's a cyst. Simple, yeah. CT is quite straightforward, actually. It's probably the easiest thing to understand in radiology. If that Hounsfield unit value was 50, what would that be? Would you think? Tissue, yeah. So an abnormal tissue growth from the kidney, what would you think that might be? A tumor, such as an RCC, exactly, yep. If that was around minus 80 Hounsfield units, what do you think that would be mainly made of? Fat, that's right. And a lesion arising from the kidney that has a lot of fat in it. Any ideas what that might be? Angiomyolipoma, yes, that's right. So you can begin to see how just by understanding the very basic concepts, you can begin to actually do differential diagnosis and actually do radiology. Yeah, CT in particular is not that difficult to grasp. So once you've understood the concepts of Hounsfield units and the different sort of tissue ranges of Hounsfield units, you can get started. The next thing to understand is about windowing. So you can see here that we can see the organs in the abdomen very nicely, but we can't see the lungs particularly well. We can change the way the image looks. Okay, this is what we call a lung window. And now you can see all the detail in the lungs, but the abdomen looks a bit rubbish, right? Or you can do this and put it on a bone window. And now, if you look closely at the bones, you can see lots of detail here. You can see the joints, you can see the cortices and the medulla, which on a normal sort of abdominal window, you just can't see very well, right? So you've got lots of different windows that help you to appreciate different kinds of tissues. You've got like lung windows, bone windows, tissue windows, you've got liver windows, brain windows, all sorts of different windows. And what we're really doing with our windows. So, as I said, the Hounsfield units range from minus 1,000 to plus several thousand, right? So there's loads of different Hounsfield units, but our eyes can only see about 20 or 30 different shades of grey. So there's no point having loads of different shades of grey for every single Hounsfield unit point. Does that make sense? Yeah. So what you do is you group your Hounsfield units into 30 different shades of grey, right? So that your eyes can actually appreciate the differences between these tissues. And the way that you group those Hounsfield units determines what your window looks like. So when I'm changing this like this, doing different windows, I'm not actually changing the Hounsfield unit values. Those are set. Okay. All I'm doing is changing the way that that's distributed, right? So if your greys from black to white are focused in on the range where soft tissues are, so minus 100 to plus 100 or something like that, then you get something like an abdominal window. Where would you concentrate your Hounsfield unit values if you want to look at the lungs? Where would you put your Hounsfield? Where would you put your greys? Where would you concentrate them? So, so yeah, you would put all of your greys in the low end of the density spectrum because your lung tissue is very low density because it's mostly air, right? What about if you wanted to look at the bones? What would you do? The opposite, exactly, the exact opposite. So you'd put all of your greys in the upper end of the spectrum. That's why everything else looks a bit rubbish because you've run out of greys basically to use. So your eyes can't really differentiate the differences between the organs. Does everyone understand that? Yep. So that's a really important concept to grasp in understanding CT. And I promise this will become useful when we're actually looking at things. So that's concept number two. The next concept to understand is about contrast. I'm not talking about image contrast, I'm talking about contrast medium. So you're probably aware we often give injections in CT. Why do we give injections? Well, the injection contains iodine, and iodine is whereabouts in the periodic table? It's quite low in the periodic table, which means it's very heavy, which means it's very dense, which means what it will look like on CT? It will be bright. Yeah. So if you inject iodine, okay, into someone's vein, and you've got an organ that's well perfused and that gets lots of that iodine in there, what will happen to the organ? It will look nice and bright. Okay. So exactly how it will look will depend on exactly how long you wait after you inject the contrast. You may have heard about phases like triple phase, dual phase, all that kind of stuff. This is all related to that. Okay. So when you give the contrast, if you wait a very short period of time, the contrast will go into the veins, end up in your SVC, go into the right side of the heart, and then where's it going to go from there? Into the pulmonary arteries. So if you're doing a CTPA, that's when you take your scan. Does that make sense? Because you want the contrast to be in the blood vessels, in the pulmonary arteries, because the contrast doesn't penetrate clots. So if you've got clot in the arteries, the artery will be nice and bright, except where you've got the clots. So you get a little dark filling defect where the clot is. Does that make sense? Yeah. So that's basically what you do if you're doing a CTPA. Okay, you wait a very short period of time for that. But if you're doing interest in the abdomen, that's a very useless sequence, isn't it? It's a very useless phase for looking at the abdomen. So what do? We wait longer. What's the contrast going to do next? It's going to go into the pulmonary veins, into the left side of the heart, and then from there it's going to go into the aorta. So if you're doing an angiogram, looking at the aorta for a triple A or something like that, that's when you do your scan. Does that make sense? Yeah. So all depends on exactly where you want your contrast to be, and that will determine what phase you use. Right. So if you're looking at the abdomen, what you usually want is a portal venous phase, which you may have heard before the term. What that means is you wait, the contrast goes out into the aorta, out into the SMA, feeds the bowel, comes back via the SMV into the portal vein, and then fills the liver. That's when you do your scan. It's about 60 to 70 seconds. That's when you do your abdominal scan. So if you're doing an abdominal scan, I'm a georadiologist, so it tends to be my sort of area of interest. But that's when you would do your scan. Does that make sense? Yeah. So why would you do a triple phase study? Any thoughts about why you might want to do a triple phase study? So sometimes you might be interested in the arteries and the veins. Okay. So, for example, if someone is having GI bleeding, right, what you're looking for is you want to give contrast and you want to basically see contrast going into the bowel. Because obviously, normally it wouldn't do that. Okay, it stays in the blood vessels, stay in the mucosa, but it wouldn't go into the lumen of the bowel. What you're looking for is the actual bleeding. So you're looking for blood and contrast going into the lumen of the bowel, right? And that, if for example, if it's like an arterial bleed, which is the most common, you'll see on the arterial phase, right? But you also want to do a portal phase as well, because that actually gives you a bit more time to capture the bleed, because these bleeds are not continuous, they're intermittent. It bleeds and it clots off, and it bleeds and it clots off, and it bleeds and it clots off. So it's an intermittent thing. So if you happen to be lucky and you catch it on the arterial phase, then great. But if it didn't happen to be bleeding at that time, you won't see it. So by doing a sort of a portal phase, you then have another sort of 40 seconds or so, okay, within which time, if it bleeds, contrast will then enter the bowel. And when you do your portal phase, aha, we've seen the blood. The other thing it helps you with is it actually helps you to see the shape of the bleed to make sure it's not just a contained pseudoaneurysm, it's an actual genuine bleed. And so this case, for example, is that here we've done a triple phase. So here you can see there's no contrast. See, everything looks kind of dark. Here, the brightest thing on the screen, apart from the bones, is the aorta. So this is an arterial phase. And here you can see the aorta is not quite as bright. If you go up to the liver, where you can see that's the portal vein, you can see is just as bright, if not slightly brighter than the aorta. So that's a portal phase, right? So we have a triple phase study. Why do you want to do a pre-contrast? Yeah. So for example, let's have a look at this bit of bowel here. Can you see there's a little bright thing in the bowel? Okay. But without a pre-contrast, you won't know whether that was just a tablet fragment or something that the patient ate, or whether it's genuine contrast extravasating into the bowel lumen. That's why you do a pre. Can you see it on the pre? No. Therefore, that must be contrast. Okay. And then what is it doing on the portal phase? It's puddling. You see here, you can see there's a little jet as well. You see a little jet of blood coming out, and there's a little sort of beginning to puddle here. But on the portal phase, you can see it's beginning to pool and form a little pool of blood. So that is how you diagnose bleeding, GI bleeding. Okay, that's why you do a triple phase. So understanding contrast phases helps you to understand why we do a triple phase scan or dual phase scan or whatever else. Does that make sense? Yeah. There are all sorts of other reasons why you might want to do a triple phase. So, for example, if you're looking at the pancreas and you're looking for pancreatic tumors, well, some pancreatic tumors, like adenocarcinomas, are hypovascular. Okay, so they don't contain as many blood vessels, right? So, when you're doing a CT, you'll see the rest of the pancreas enhance, and the tumor itself doesn't enhance very well. Okay, and sometimes you see that best on the portal phase, sometimes you see it best on the arterial phase. But some tumors, like neuroendocrine tumors, will enhance really avidly because pretty much any sort of tumor that produces hormones will enhance quite avidly because it needs a blood supply in order to release its hormones, right? So nearly all neuroendocrine tumors will do that. And pancreatic neuroendocrine tumors are no exception. Things like insulinomas, glycogenomas, etc., etc. So you want the arterial phase to see, is it a really brightly enhancing lesion, in which case it's a neuroendocrine tumor, or is it a hypovascular lesion on the portal phase or the arterial phase, in which case it's more likely to be an adenocarcinoma. So it can really help you to characterize lesions, because different lesions will enhance differently depending on what their blood sort of supply is like. Does that make sense? Good, excellent. So that's a case of GI bleeding. Let's move on and look at something else. And let's talk about a different concept. So we're talking about contrast enhancement. Obviously, you're looking at lesions that might be enhancing, but you're also, don't forget, you're also looking at the enhancement of the organs themselves. Okay. So for example, this patient, okay, let's go very briefly through the anatomy. What organ is that? Liver. What's this one? Spleen. What's this one here? Stomach. What are these two back here? Excellent. And what's this thin thing coming across there? That's pancreas. Excellent. And these are all bowel loops, right? So, what do you notice about vessels here? So this is the aorta here, for example. What do you notice about? Yeah, because you can see all this dense stuff. And how dense is it? It's calcium dense. So that's calcification. That's atherosclerosis, right? So let's have a look at the bowel. So you can see here you've got some bowel which is enhancing quite nicely, and then you've got some bowel here which looks different. Can you see the wall of this bowel here is not as bright as, for example, the wall of that bowel there? Yeah. So what do we call it when? So if it's not receiving contrast, what does it mean? What does that mean? It's ischemic. Exactly. Exactly. So if you're looking for ischemia, you're basically looking for alterations of the enhancement. Okay. So again, we can also see here the spleen. What do you think about the spleen? Because you've got a bit of the spleen here that is enhancing, and you've got a bit of the spleen here. It's a bit darker, isn't it? Okay. You can actually use a different window to really highlight that. So what does that mean? Splenic infarct, exactly. Yeah. So you've got splenic infarct and you've got essentially a bowel infarct, right? So in this case, what phase would be really useful? We want to see an arterial phase, don't we? Because what we want to know is this venous ischemia or arterial ischemia? Is it the vein that's blocked or is it the artery that's blocked? The portal venous phase is great for looking at the veins to make sure that they're patent, okay? So here, for example, you can see that's the SMV here. You can see it's nice and patent. It's got contrast coming in. It's a bit squashed by the distended stomach, but you can see it coming up here, through pancreas, and then going up into the liver. And that's portal vein there. Okay, so that's fine. But then you want to assess the arteries. And what did we say? You want, in order to assess the arteries, you ideally want to have an arterial phase. So let's have a look at the arterial phase, and let's put it on the vascular window. Okay, so in terms of the branching points of the aorta, let's talk about that a little bit. So, what's the first branch of the abdominal aorta? Celiac trunk. That's right. And you can see it sort of branches out like this in a little fork, common hepatic artery and splenic artery, and then you also have the left gastric artery coming off it as well. And what's the second one that comes off? Supramesenteric artery. And which is the one that supplies the small bowel? Supramesenteric artery, exactly. So this is the one that we're interested in, yeah? So what we're looking for is any filling defects within the vessel. So you follow it, follow it, follow it, follow it, follow it, follow it, follow it. Look, these are the branches as well. You're also looking at those too. And oh, look, there's a little branch. You can see it's a branch because it's got that same atherosclerosis around it. But what do you notice inside it? It's exactly, it's not filling. Yeah, can everyone see that? You've got atherosclerosis here, but you've got contrast in the middle. You've got contrast in the middle of that vessel, but these vessels here do not have any contrast in them. And then suddenly you get a little bit of contrast and it goes away again. And then maybe little fragments of contrast here and there. But the most of those vessels is completely occluded. So this is arterial ischemia due to occlusion of the SMA. And going further than that, because as a radiologist, it's always about going beyond, um, we've got occlusion of SMA branches, but we also know that we've got splenic infarct. So that means we've got two different vascular territories. So what does that mean? If you've got two different vascular territories which are involved, is this in situ thrombosis or is this embolism? Embolism, exactly. You see what I mean? So you sort of, as a radiologist, you're going through logically, and you really have to sort of take it as far as you can, really, in terms of the logic of thinking about what you're actually dealing with, and think. Yes, anyone can say, okay, there's an occluded thingy, and then there's splenic infarct. But then to say, actually, we think these are embolized, so let's look for an embolic source. Okay, so let's see, do they have AF? I think this patient did have AF, so this could be coming from the left atrial appendage. Yeah, little clots flying off or something like that, right? Um, if the patient, for example, had a DVT and they had this, what would that make you think of? Because that doesn't make sense, does it? Why would the DVT end up in your arterial system? Sorry? Exactly. So that tells you there must be some sort of a right to left shunt in the heart or somewhere that's taking a clot from the systemic veins and putting it back in the systemic arteries without going through the lungs first. Because that's obviously the DVT would normally get stuck in the lungs. Yeah. Does that make sense? So these are the kinds of the things that you'd be thinking of as a radiologist to help you to make a diagnosis. Okay. So let's have a look at something else. Just keep an eye on the questions in the chat. So let's have a look at something else. Right. So this patient. Okay. So next sort of important concept to grasp is the concept of fat stranding. You may have heard that term before used by radiologists and wondered what it actually means. Fat stranding is basically edema within fat, right? When things get inflamed, you get edema. And edema basically is little strands of fluid that go in between lobules of fat. Pretty much every organ in our abdomen is surrounded by fat. So if an organ is inflamed, the fat around that organ becomes stranded, basically what it means, right? Fat normally should look clean, like this subcutaneous fat. Okay, you don't want to see little streaks of stuff in it. You have to be careful to avoid vessels because these are just vessels. This is not stranding. Okay, but you want to see strands of stuff, right? And the organ that's surrounded by the stranding is the organ that's inflamed. So if you see fat stranding around the pancreas, it's diverticulitis. We see fat stranding around the gallbladder, it's cholecystitis. We see fat stranding around the sigmoid diverticulum, it's diverticulitis. We see fat stranding around the appendix, it's appendicitis. Simple. Yep. CT is really easy. Okay. So let's have a look at this case, and I want you to tell me when you can see some fat stranding. So we're not looking at the organs, we're looking at the fat. And I want you to tell me when the fat starts looking dirty. Yes, and which bit of the abdomen? Right or left? Right. Here. Can everyone see clean fat, dirty fat? Yeah. This is fat stranding, right? So it's the right side. Is it sort of right upper quadrant, right flank, or right iliac fossa? Right iliac fossa. So then you got to think, okay, causes of fat stranding in right iliac fossa. Part number one, appendicitis. So already, without even finding the appendix, already you're thinking, right, I'm thinking appendicitis. I'm thinking Crohn's disease. I'm thinking right-sided diverticulitis, maybe, or some sort of a right-sided colitis, or it's something like that, right? So these are the kinds of things that you're thinking of, right? So already your mind is working. Okay, this is what you've got to be like, as a radiologist. You're already thinking, right? Okay, this is my differential diagnosis. Let me narrow it down further, right? So first thing we're looking for is appendicitis, right? So how do we find the appendix? Well, start off at the hepatic flexure, and you follow the colon down. So this is ascending colon. Look at the wall, nice and thin, doesn't look particularly thick-walled or edematous. You start to get some stranding. What do you notice about the wall of the colon as you're coming down? Starts being nice and thin, and then what happens to it? Thickened, yeah, exactly. So here you can see that's the serosal surface. This is the enhancing mucosa, and then you've got this really edematous wall. Look how thick that wall is, really, really thick and edematous, right? Here you come down, and you can actually see here, this is the terminal ileum coming out of the colon, which also appears a bit thick wall, doesn't it? You can actually sort of measure the wall that's quite thickened there, right? Um, you can actually then follow the terminal ileum and prove it's not appendix because it sort of continues on and joins other small bowel loops, etc. Okay, so we found terminal ileum. We found ileocecal valve, which is around about here. You can see there's a little streak of fat in it. That's quite common. There's a nice anatomical marker for where the ileocecal valve is. So the colon beyond this point must be cecum. So we're going to be looking carefully around the cecum to see if we can see any blind ending tubular structures. You may have noticed that there's a tubular structure here, right, which comes up here and happens to be blind ending. Yeah? So this is appendicitis. But as a radiologist, you don't stop there. You take it further, okay? Take it one step further. Right, so it's an appendicitis, right? You can see the appendix is distended. You can see the wall of the appendix is minimally thickened, but it's enhancing quite a lot, isn't it? Compared to like other loops of bowel, it's actually enhancing quite a lot. Why? Because inflammation leads to vasodilatation, which means more contrast and more blood gets to that organ. Does that make sense? So inflamed things generally tend to enhance more because you get more of the contrast. Yeah, so beginning to sort of put all the stuff we've been talking about together, right? So you've got appendicitis, but let's have a look at the appendix and follow it into the cecum. So you can see an enhancing wall, enhancing wall, enhancing wall, thickened enhancing wall, thickened kind of enhancing wall, and then what happens to the wall? Where's it gone? Yep. So it could be perforated, or it could just be ischemic, couldn't it? Exactly. So we've now not only said this is appendicitis, but we've now upgraded that to gangrenous appendicitis. Yeah, because you've got a bit of the wall that is not enhancing. As we've described, if a bit of normal stuff that should be enhancing isn't, it means usually it's ischemic or it's infarcted. Does that make sense? Yeah, everyone following me so far? So, um, so we've got gangrenous appendicitis. And let's follow the line of the appendix up because you know that it's going to be following that kind of line. Follow it up. And what's this? Exactly. So that's a fecal or in the appendix we call that an appendicolith, but basically it's a fecalith in the appendix. And you can see that's right at the base of the cecum, at the cecal pole. So this is the cecum here, right at the cecal pole. At the base of the appendix, you've got that appendicolith that's stuck there. So that's the cause of the appendicitis, right? But then, okay, so we've identified cecum, we've identified terminal ileum, we've identified appendix, and we can see the appendicular there. If that's all fine, but what are these things? Because these are not in the line of the appendix. So what do you think these things are? Because the appendix is down here, isn't it? Yeah, you can follow it. So where are these? Are they in bowel? Yes. So now we've confirmed that it's not only gangrenous, but it's perforated. Yeah, because these are further fecaliths that have spilled out into the peritoneal cavity adjacent to the appendix. Does that make sense? Yeah, because we know that they're not in bowel. You can actually see that they're not in the line of where the bowel is, right? So we've now said we've not just stopped at this is appendicitis. We've said this is gangrenous, perforated appendicitis with spillage of fecalis into the surrounding tissues. So do you see the sort of process of sort of diagnosis? It doesn't just stop at the diagnosis. It's also about, okay, well, what's actually happened? What are the complications? Has it perforated? Is it gangrenous? What's sort of going on? Does that make sense? Yeah. So this is all parts and parcel of being a radiologist. Show you another case here. So here we've got another CT scan, and again, what I'm going to do is I'm going to scroll down. I want you to tell me when you can see the fat stranding. Okay. So let's go down and see. So tell me when you can see. So first things first, what can you actually see in the lungs here? Yeah, it's definitely fluid, isn't it? Right? Yeah, around about close to 0 Hounsfield units. Yeah, so we've got fluid effusions. What's this dense stuff here on top of the fluid? Sorry? No, it's just sitting on top of the fluid. It's not pleural thickening, but you're thinking along the right lines. This is collapsed lung. So this is atelectasis. Because obviously that fluid is taking up space that lung used to be. So the lung that used to be there has to collapse in order to allow the fluid to exist, right? So this is basically just collapsed lung, right? So that's just a bit of atelectasis. So first things first, pleural effusions. What's this structure here behind the heart? Contains fluid. It's not the aorta, but it continues down
IBC.
into the stomach. Esophagus, yeah. And what's this structure within the esophagus here? Tubular structure. It's an NG tube, yeah. So first things first, okay, don't forget about your tubes and lines. Is the NG tube in the right place? Does it go into the stomach? What does it do? It's coiled in the esophagus. So the first thing you would say in your report is the NG tube is misplaced. So this isn't, there's a lot to radiology. It's not just about making a diagnosis. It's also about spotting other things that might have an impact on the patient. Because obviously, if they don't put that NG tube in right, the patient could vomit, aspirate, and then things get much worse for the patient, right? So let's go further down. Can we see any fat stranding? Yes. Where is the fat stranding? Or what organ is surrounded by the fat stranding? Yeah, so that's the pancreas here. And look, all this, it's not just fat strand. This is actually just frank free fluid as well as fat strand. You can see it surrounding pancreas. It's clearly not involving the kidneys here. Okay, you can see the patient's had a cholecystectomy. They've got some cholecystectomy clips here. They don't have a gallbladder there. So this is pancreatitis. Are we going to stop there? No, exactly. So what are we going to say about this pancreas? Well, how do we categorize pancreatitis in terms of prognosis and things like that? So acute, this is definitely acute because you've got all that fat stranding. It tells you that's acute. And acute pancreatitis, you've got two types: interstitial pancreatitis and necrotizing pancreatitis, right? So what do you think the difference between the two would be on a CT scan? That one will look darker. Yes. So necrotizing pancreatitis, it's in the name, bits of the pancreas are necrotic. If it's necrotic, is it enhancing? No, right? It doesn't mean the whole pancreas isn't enhancing. It could just be focal bits of the pancreas that aren't enhancing. So this is what you look for, right? So you've got pancreatitis and you're looking to see is the pancreas enhancing. Well, this bit clearly is. Follow it. So that's tail, this is body, this is neck, go into the head. Head of the pancreas is kind of enhancing. But what about this bit of the head? There's a chunk missing, right? So this is a necrotizing pancreatitis. It's a bit of the head in the uncinate process that is not enhancing. This part is fine, but then up here you can see that bit stops enhancing. So this is necrotizing pancreatitis. Okay. And I think in this patient it was sort of alcohol related, but you would also look for other causes, right? So you look for gallstones, etc. So So this patient has necrotizing pancreatitis, and why is that bad? Because I mean, it's a pretty horrible thing to have. Um, if we have a look, they get really horrible complications. So here, for example, look at what happens. Big collections, yeah, not quite a pseudocyst yet, but it's a big collection. Lots of fluids. This is what third spacing is. You probably heard of third spacing, never known what it really means. This is what third spacing is. It's just fluid that's not in your intravascular space. It's not in your intracellular space. It's just floating within your abdomen, right? And these patients often have multiple CT scans as follow up and things like that. And you can see that it's all gone horribly wrong. And again, you're looking for complications, right? So, what complications are we looking for? Well, in this particular case, if you're looking at the sigmoid colon, okay, which is this structure here, you're following it up here, it looks a bit ropey, right? You put it on lung window, okay, and what do you notice adjacent to the sigmoid colon here? There's gas, right? And you can see the wall of the colon, which is here, has got little holes in it. See these little holes? Yeah? So what's happened? Perforation. And look, on the lung window, you can see free gas really nicely. Look at these tiny little bubbles of free gas. Yep, sitting obviously anteriorly because gas rises. Yep. So you can see lots of free gas and even more free gas up here, right? Which is much more difficult to appreciate on the normal abdominal window because it's not sort of highlighting the air, right? Whereas on the lung window, suddenly it's like really blindingly obvious. Okay. So this patient has developed necrosis of their sigmoid colon. So ischemia, infarction, necrosis, perforation of the sigmoid colon as a complication of their pancreatitis. Does that make sense? Yeah. So again, as a radiologist, these are the things that we do. Okay, you're looking not just at because this patient obviously has a CT for ongoing pancreatitis, whatever. You're not just looking at the pancreas. You're looking at other things. What else is going on? What's sort of going on? And this is what makes radiology quite fun because you are putting together quite often. You're putting together a lot of disparate findings into a single diagnosis, or you're looking for other things that non-radiologists won't necessarily be able to spot. So let's have a look at something else. Look at this case. So, and I'm showing a lot of abdominal CTs because I'm a GI radiologist. But okay, so what's the first thing you notice? Sorry, so I am quite literally half deaf, so you will need to speak. So you got some things in the liver. So what are they? What are they made of? Are they cysts? So if you're not sure, you can always measure the Hounsfield unit value. It's about 43. So are they cysts? No. Okay. So what do you think they could be? Yeah. So you've got multiple soft tissue density things in the liver, right? Some of which are really quite large. So they could be metastases. So what are you going to do next? You also notice, by the way, in the lungs, if you put on a lung window, what do you notice in the lungs? Exactly. You can differentiate the nodules from the vessels because the vessels you can follow up and down, and the nodules just appear and disappear. They blink in and out of existence as you're scrolling over them. Does that make sense? Yeah. Lung metastases, liver metastases. So what are you going to do next? Look for a primary. Exactly. So where would you look for a primary? What would be your number one sort of place? Bowel, lung, absolutely. So let's have a look and see if we can see any bowel lesions. So if we have a look here, you can see the anal canal coming up into distal rectum. And then what do you notice about the distal rectum here? What do you about the wall of the distal rectum? That is very thick, isn't it? Yeah, it's very, very thick. Okay, so this is a rectal tumor. What's this thing here on this pelvic sidewall? That's a lymph node. Yeah, so you've got pelvic sidewall lymph node. And if you follow the sort of rectum up, what's this thing here? Okay, if you follow all these superior rectal vessels up, that thing there is another lymph node mass. Okay, so you've got a big superior rectal lymph node mass. You've also got this really unusual tongue of soft tissue that heads up this way alongside the artery. And if you actually follow it, you'll notice it then turns into a vessel. You see that? See that? That turns into a vessel. Goes from a vessel to being this sort of soft tissue filled thing. That is what we call extramural vascular invasions. That's where the tumor actually invades into the vein. Okay. And this is a really extreme example of it where it's actually gone all the way up the vein. So this is the IMV here, the inferior mesenteric vein. It's gone all the way up, okay, almost to the point where the aorta sort of bifurcates. Okay, so it's quite extensive. So this is a rectal tumor. Okay, so you've now diagnosed a rectal tumor with liver and lung metastases. Yeah, you see how this is basically our job. Yeah, as radiologists, this is what we do. This is our day job. So let's have a look at something else. Right. So let's have a look at. So sometimes you might have a patient who has a mass and you're not quite sure where it's coming from. Okay. In that case, it was quite easy because you can quite clearly see that there was a rectal tumor and you've got some stuff going on in the um, in the nodes and in the liver. But sometimes you might have a patient like this where you're kind of like, well, okay, so where's this thing coming from? So this patient, quite young, 24-year-old, stomach, spleen, pancreas, mass, right? So where's it coming from? Because this is always a thing. If you see a mass, the first question is where's it coming from, right? Is it coming from kidney? Well, no. You can actually just about see there's a thin plane of fat. Yeah, fat's really useful on CT. Okay, it's a thin plane of fat separating the mass from the kidney, so it's not coming from kidney, right? Okay, fine. Um, is it coming from pancreas? Well, it could be because you've lost the fat plane here, haven't you? Yeah, so it could be coming from pancreas. Could it be coming from stomach? Well, in certain parts, you've also lost the fat plane of the stomach, so it could be coming from the stomach. Are there any other organs nearby? Well, not really. I mean, this is the adrenal gland here, this little triangular structure above the adrenal, above the kidney. It's clearly not coming from that. Could it be coming from some of these bowel loops? Well, maybe. I mean, they kind of look just a bit squashed rather than anything else. So our main thoughts are: could it be coming from pancreas? Could it be coming from stomach? So then your thought processes are like, all right, okay, what's the differential diagnosis? Okay, for a mass that looks like this, that's hanging off the stomach, and what's the differential diagnosis for a mass like this that's hanging off the pancreas? Right? In context of the patient's gender and age and demographics and everything else that's going on. Right? So, any thoughts? Feel free to shout out. So it's pancreatic cyst. So next question is it cystic? So this portion here is quite low attenuation. This portion here is much more high attenuation. So this is a mass with some soft tissue elements and some cystic or necrotic elements. Okay, so it's a mixed sort of solid cystic mass. Okay, so it's not a simple cyst. No, go ahead. So in a patient of this age, you might be thinking of some sort of germ cell tumor. More common in the retroperitoneum, more common in men. Okay, so again, it's all about putting it together with the demographics and stuff. Okay, so it's not quite the right place and not quite the right demographics, but that's a good suggestion. Any other thoughts? The patient actually initially came for an ultrasound for right iliac fossa pain. This was found completely incidentally. Have no symptoms related to this, but you're absolutely right to think about night sweats and things like that because that makes you think, for example, lymphoma. Okay, now in terms of appearance, lymphomas usually don't look necrotic unless they're incredibly high grade. They usually look fairly sort of solid. So the appearance can also help you to guide your thoughts. Okay, so this is probably not a lymphoma. Okay, any other thoughts? Yes. So yeah, so a pseudopapillary tumor of the pancreas. Okay, um, perfect demographic, young women. Okay, that's where they commonly come from, and they come off the pancreas, and they most commonly look solid cystic, and so that is definitely quite high up in your differential. If it was coming from the stomach, big exophytic mass coming from the stomach, and do you think? So endometrioma is a good thought, okay? Because we're don't you're absolutely right in not just tunnel visioning into tumor, okay? Because not it won't always be cancer, okay? Sometimes it's other things. Like GIST. So GIST is another thought, absolutely. So GIST and pseudopapillary tumor will be probably your number one and two. Endometrioma, you're right to think of, and so for example, for that, you'd be looking at the pelvis to see is there any evidence of pelvic endometriosis? Because usually there will be if they've got endometriosis elsewhere. Okay, so you might look at the uterus, you might look at the ovaries, and actually there aren't really any endometriotic cysts in the ovaries. The uterus looks kind of okay. Not much going on in the pelvis in terms of sort of adhesions or endometriomas or that kind of stuff. But it's definitely something to think about. Okay. Um, I won't go into the appearances of endometriomas because they don't usually look like this, but it's a good thought, okay? Because again, it shows that you're thinking about okay this particular patient, okay, and they're given their age and everything else. What other things could it be? This turned out to be a pseudopapillary tumor of the pancreas, interestingly enough. But yes, I wanted to show you that case just to show you the kind of thought processes that you go through as a radiologist when you're dealing with a case like that, and you're like, oh God, what's going on? I appreciate that at this stage, a lot of you will be like, oh, like I wouldn't ever think of things like that. But this is what comes with radiology training. So this is why it takes 5 years to sort of train up as a radiologist. So let's have a look at something else. Um, so let's have a look at this. So this patient was quite unwell, kept dropping the hemoglobin, to give you a bit of a clue. Now, in this case, unfortunately, we didn't do a triple phase. If you look at this patient, first things first, they're intubated, right? That's not a good sign, right? Generally means patient's really not well, right? What's going on in the abdomen? What's all this stuff here around the spleen? So here's the question: is it fluid? What's the density? It's a bit higher than fluid, isn't it? It looks like fluid, but it's much higher than density. Blood, exactly, because blood contains iron, which again is a bit low on the periodic table, a bit more dense, higher density, right? So high attenuation value, right? So we've got blood in the peritoneum. So we've got hemoperitoneum. Okay, you can see that really nicely in the pelvis here as well. This is all hemoperitoneum. Right, so where's it all coming from? You clearly see the liver looks abnormal, right? You've got bits of liver that are enhancing, bits of liver that look really weird and aren't sort of enhancing quite as well. And then you've got gallbladder. Now, what do you notice inside the gallbladder? Given this is a portal, well, supposed to be a portal venous space, it is a portal venous space. This dense stuff here, you can see layering, can't you? So you've got fluid, which is bile, and then you've got high density clotted blood, right? And sitting on top of the clotted blood, what do we have here? It's a little puddle of contrast, isn't it? Yeah. So we haven't done an arterial phase here, but the patient is bleeding so briskly that we're able to see it really nicely on the portal venous phase. And where is the gallbladder bleeding into? Bleeding into the liver. So this actually is a massive sort of hematoma within the liver. So you've got a bleed. Which artery do you think this might be coming from? Given it cystic artery, exactly, because the bleed's coming from the gallbladder, right? Why is that important? Why does it matter which artery it's coming from? Yes, because what's this patient going to have next, right? So again, radiology is not just about diagnosis. We also do treatment. So here, these days, back in the day, patient has a big bleed. What happens? They open them up, 4-quadrant, take everything apart, try and pack things and stop the bleeding. These days, we'd send them up to IR, yeah, and the interventional radiologists sort it out. So here we go. Here's an angiogram. These are the hepatic arteries, as you can see. And I'll skip forward to where the bleed is. Look at that big blush of contrast. See that? The arteries are filling, but then look at that. That's not within an artery. And that there looks like it's filling into the gallbladder. Yeah. So what they do, put some coils in, do another run, and look, the bleeding stop. No more bleeding. See that? So on this run, you can see active bleeding. They had put a coil into another artery which they thought was bleeding, and it turned out it wasn't. And then they put another coil into the cystic artery here, and then the bleeding stops, and the patient is fine. Okay. So this case is quite nice because it demonstrates sort of a bit more of a range of radiology, right? It's not just about diagnosis; it's also about treatment. This one here, this is another case where we did treatment. This is hot off the press. This was 1 o'clock in the morning last night. I was called because I do pediatric on call. I'm not actually a pediatric radiologist, but I do some pediatric radiology on calls. And let me just pull these across to here. And as part of my pediatric radiology on call, I am involving diagnosing and treating interceptions. Okay, so this is a 1-year-old who came in with an interception, and we reduced it. So what do you do? So an iliac interception is basically when the small bowel goes into the large bowel. Okay, causes obstruction, PR bleeding, all that sort of red currant jelly stool, which you may remember from medical school. So that's what people's way. So the patient had an interception. What do? We basically insufflate gas into the rectum, and you then push back using the gas pressure. You push the interception back. So here on the first run, you can see there's a little catheter balloon here in the rectum. There you can see the gas going up into sigmoid, going up into descending colon, and then coming into transverse colon. Yeah. So it's coming into transverse, and then the gas kind of stops here. That's where the interception is. And then as you sort of pushing through, you'll notice the gas goes towards hepatic flexure. That's the hepatic flexure here. And then you can see a little bit later, oh, there it is, pushing down into ascending colon. You can see the head of the interception just there, right? pushing it down, it's coming down, 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 and then eventually, baby obviously is very uncomfortable at this point, because it's not nice to have your colon filled with gas. It can be quite painful, which is why we give them morphine. And then you can see ascending colon, and then the intussusception's gone all the way back into ascending colon, and it's sitting in the just beyond the ileocecal valve. Okay, and you can see it just stays there. Okay, so it doesn't reduce any further. And what we're looking for when we're doing this is a gush of gas into the small bowel, right? And it just stays there for the whole of the 3 minutes that we were doing the intussusception reduction there at 80 millimeters of mercury. It stayed there. So then you wait 3 minutes and then you try again at slightly higher pressure. So this time we did it at 100 millimeters of mercury. So again, you can see gas coming up into hepatic flexion, ascending colon. There's your intussusception there. You can see that little filling defect or mass. You go, 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 and then, oh, does everyone see that? There it is. And watch what happens. Boom. Everyone see that? It pops back. It's the most satisfying feeling, honestly. I can't tell you how satisfying it is. When you see the intussusception, you see it, and then pop, and then you get this gush of gas going to terminal ileum. That's terminal ileum then, that's ileocecal valve. You can see it go there, pop, and then the baby goes, and they just relax, and everything's fine, and they don't need surgery. And yeah, it is honestly one of the most satisfying things. So, and then you can see some more gas sort of filling small bowel loops and things like that. So, yeah, it's not all about CT. It's also about other things as well. And as radiologists, we do quite a lot of treatment as well. Interventional radiologists to a certain extent, the pediatric stuff as well, the intussusception reduction. It's very satisfying. It is very, very satisfying. So let's have a look at something else. So this is a case where it's quite complicated, okay, but this is the kind of stuff I live for. It's the most fun in radiology is when you got someone who's got lots of things going on. You're trying to like put it all together, and it's like a puzzle. You're putting it together, but it feels like you're feels a bit like being Sherlock Holmes, sort of putting together a puzzle. So this patient, what's going on? So you're looking at this patient, and you're going down, and you've got some weird soft tissue around the aorta and around the celiac axis. Okay, fine. And then you're looking at the bowel, and you're seeing all these little enhancing things here coming off the bowel. There's a really big one in the jejunum. Can everyone see that? Really big enhancing mass in the jejunum. And the more you look, the more you see. There are other sorts of enhancing masses. I fully appreciate if it's difficult for you to appreciate this. That's absolutely fine. This is like I said, quite a complex case, but there are some enhancing nodules coming off the bowel here. Okay, and you've got another enhancing mass here. And there's quite a lot of them all coming off the small bowel. So it's like, okay, well, what's going on here? And then you notice that there's all sorts of other stuff going on. Look at the subcutaneous fat. And what do you notice as I'm scrolling through? There's lots of little nodules within the subcutaneous fat, aren't there? Yeah. And they're not just subcutaneous, because if you're looking at the skin surface on the lung window, what do you notice? There's lots of little nodules on the skin surface. And then you're looking at the paravertebral regions. Now, normally in the paravertebral regions here, you only see fat. But here, at pretty much every single level, you've got some funny soft tissue at the paravertebral regions, just coming out of the spine here. See that? On both sides, you've got this abnormal soft tissue here. You've also got multiple other sort of nodules in the patient's back. You've got funny masses within muscles, like this one here. You can see within quadratus lumborum, there's a funny soft tissue mass there. If you look further down, you can see this is sciatic nerve here, and sciatic nerve also has a funny mass associated with it. Does anyone know what diagnosis we're looking at here? Sorry? Yes, exactly. So this is per patient with NF1, okay, so neurofibromatosis type 1. So what do you think those small bowel things could be? Cysts, because patients with neurofibromatosis are at much higher risk of getting bowel cysts, okay? And so that's basically what they are. Could they be neurofibromas? They could be, yeah, but it's much more likely for them to be cysts, okay? And particularly when they enhance like that, they're much more likely to be cysts. So do we stop there? No. What is special about the cysts that you get in neurofibromatosis? They're generally less aggressive than the cysts you get sporadically. Okay. So this again is stuff that as a radiologist you can really help the clinicians, because you can say this patient has neurofibromatosis, multiple cutaneous neurofibromas, all those things that you see, clinically on the patient. You can also see them in radiology. You've got subcutaneous muscle, nerve sheath tumors, all sorts of things, and they've got lots of small bowel cysts. In patients with NF1, these are generally tend to be indolent and can be followed up. And then usually what they do is that when they get over 3 centimeters, they cut them out. Okay, that's basically what they do. The only one here that's bigger than 3 centimeters is this one here. So that might be one which they might consider cutting out. So does that make sense? This kind of stuff is really good fun. You know, putting together different different sort of findings from different places, and trying to come together with a diagnosis. And the one thing I will say, as a radiologist, you will see more interesting cases and more rare things than you will ever see in any other specialty. And the reason for that is partly because as a radiologist, you can report more cases in a day than you can see in AMU, right? Okay. In a 12-hour shift in AMU, you might see 10 patients, 12 patients, depending how fast you are. In a 12-hour on-call shift in radiology, you might report 30 or 40 CT scans, right? So you just the volume of stuff you get. Secondly, um, don't forget that um, the things that come to radiology generally tend to be the interesting cases, right? You don't get your UTIs and your things like that. You know, they don't come to radiology, right? They only really come to radiology if there's something interesting going on. If you think this might be something interesting going on, that's another reason why you see more interesting stuff. And the other reason why I see some more interesting stuff in radiology than any other specialty is because everything is stored forever. For patient, if you see an interesting case in AMU, patient goes home. That's it. No one else can benefit from that. If you see an interesting case in radiology, you take the number down, you show people, you know, look at this cool thing I saw on call yesterday. And you just get to see so much stuff. And you see stuff from other hospitals, you know, you see stuff when you go to conferences. You just see so much interesting stuff. This is a really complicated patient who's got a really rare diagnosis. This is Erdheim-Chester disease. The patient's got that, and they've also got CMML as well. And they've got really weird stuff going on. They've got these weird hairy kidneys, which is actually a sort of characteristic feature of Erdheim-Chester. They've got this weird sort of stranding and soft tissue and thickening of the terminal ileum, which is probably their CMML. And then they had a PET scan as well. So again, you know, with radiology, it's not all about CT. You then have various different modalities that can help you. So this patient had a PET scan, and the PET scan showed stuff that you don't see on the CT. So just quickly show you that. So let me just show you this one here. So this is the MIP of the PET, and you can see just uptake all throughout the bones here. That's all their sort of Erdheim-Chester disease. Lots of uptake in nodes. A lot of what you're seeing here is in nodes. The stuff in the abdomen you're not seeing quite as well. You can see the kidneys are hydronephrotic because of all that sort of soft tissue around them that's causing that. And yeah, this patient had Erdheim-Chester disease, and that might be something you've never heard of. But in the past sort of 10 years, I've seen at least 5 or 6 cases of it, and I've seen cases of cardiac hydatid disease, and just really bizarre things that you just find in footnotes in textbooks, and I've seen multiple examples of. It's so much fun. I honestly can't tell you just how much fun it is. And just as a final case, I'll show you one of my favorite cases that I have ever seen. Um, and this is great from so many reasons. So this patient came in with sort of left loin pain, had a CT-KUB, which just looked weird, and then had another CT scan. So what's the first thing you notice? What's that? Bowel in the chest. So what's that? It's a congenital diaphragmatic hernia. Okay, so the patient's got a congenital diaphragmatic hernia. Fine. Okay, so we've got liver. Okay, what's missing? I'll take you through the pancreas in a minute. But yeah, but we can't really see where the pancreas is. And what's the other organ we can't see? Because spleen. Yeah. Okay, so let's go further down and see what's going on. What on earth is going on here? Can you see that little swirly thing? Right? And then what is that? What do you think that is? What shape is it? Looks like a spleen, doesn't it? Is it enhancing normally? Should be enhancing like the liver. No, so it's an infarcted spleen, right? Why is the spleen down here and why is it infarcted? This is something we call a wandering spleen. So because they've got a congenital diaphragmatic hernia, they're also missing the ligaments that hold the spleen in the left upper quadrant. So the spleen is floating in the abdomen. So it's floating on its vascular pedicle. And so anything that's floating on the vascular pedicle, what can it do? Tort and twist. What other organ lives on the vascular pedicle of the spleen? Not the stomach. It's the other organ that we didn't see, pancreas, because the pancreas is stuck right onto the splenic vein. Yeah, it's actually a good anatomical marker for finding the pancreas is looking at the splenic vein. So if you follow the splenic vein here, which again isn't enhancing as it should, and then you can see the vascular pedicle twists and twists. And what's this structure here that's also twisting? That's the pancreas, right? So that's a spiral pancreas, right? And it all makes sense once you understand the embryology and the anatomy of it all, right? Because you know that the pancreas has to go where the spleen goes because it's stuck onto the splenic vein, right? So if the spleen is down in the pelvis, and you can actually see the splenic vein here comes down and then it occludes, just disappears because of the twist, right? And then the pancreas goes wee round and round and round and round, and the tail of the pancreas, so you can see it also isn't enhancing quite as well because it's also infarcted a bit, and then you end up with the spleen right at the bottom. Phenomenal case, and it blew my mind when I first saw it. But it just really highlights all the best things really about radiology. It's about figuring out what's going on when you're dealing with something where just nothing makes sense. And it is, yeah, it is in my mind, and I may be a bit biased. It's the greatest specialty within medicine, but yeah, I'm perhaps a bit biased. There we go. I think that's my time up. Yeah. Any questions? Yeah. In case you come across something you've never seen, yeah, would you, as a consultant, would you ask the other consultant? Yeah, so we ask each other all the time. This is the great thing again about radiologists. If you see something, you can ask people. You can Google it. You don't have a patient in front of you, right? So you can spend your time, right? So yeah, sometimes I spend 2 hours trying to Google what is going on with a particular patient because it's just so bizarre. Um, and um, and yeah, so the very first Chester case I did that. I was spending ages Googling because it's just like there were all these weird findings that had to be pathognomonic for something, but it just couldn't quite figure out what it was. So yeah, you ask your colleagues, you ask Dr. Google. There were various radiology websites, Radiopedia, StatDX, loads of other websites that you can use to help to find out to basically find out what's going on. Yeah, you can just look up stuff and go on Google Images, and you find a wealth of information. So yeah, that's what we do. And this the other thing about radiologists; it's a very collaborative specialty. And on the CT abdomen, you also might, like me as a GI radiologist, I might see a bone lesion, and I'll be like, I have no idea what that is. I'm not an MSK radiologist, so I'll go and ask my MSK colleague. Right? I might see something in the breast. And I'm like, oh, I'm not sure what that is. Is that a tumor? Is it something else? I might go and ask the breast colleague. So it's a very collaborative thing. We're always talking to each other. People have this idea of radiologists as people just sit in a dark room and don't talk to anyone. It's absolute rubbish. We talk to more people than anyone else, probably, because we're always collaborating with each other, with clinicians, with patients as well. If you're an IR radiologist or a pediatric radiologist or a breast radiologist, we're always collaborating. Any other questions? Anything in the chat? What happened to that patient? Someone said, what happened to that patient? Which patient did you mean? Oh, the last one. Yeah, so they had a splenectomy. They had the splenectomy. I can't remember actually whether they had their diaphragmatic hernia corrected or not. I can't remember that, but they went and they took the spleen out. The hernia was dead, basically. So yeah. Great. Thank you very much.